All right. Well, hello and welcome, everyone. We're very excited to have everybody joining us today for another fabulous webinar with some guest presenters. We have the topic today is our Hospice IDG meeting best practices. And we brought in a couple of excellent presenters from a partner company called Hospice Tools, one of the CHAP verified EMRs that we work closely with and partner with on lots of different things. So we're very excited to have a couple of guest speakers today for this topic. Before I turn it over to Ashley and Daniel to introduce themselves, I just want to say a couple of things about the logistics of today. This is going to be recorded, and the recording will be available to anyone who's registered for the event, including those that are here in the session today and those that were unable to attend. Nor will also put a link to the slides in PDF format in the Q&A. And I ask that if you have any questions throughout the presentation that you use the Q&A section to post your questions there. If we have extra time at the end, we will take a few of those questions and see if Ashley or Daniel can address them for you. And with that, I'm going to turn this over to Ashley and Daniel to introduce themselves. Thank you both.
Thank you, Denise. And hello, everybody. I'm Daniel. I do sales, marketing, and operations here at Hospice Tools. I'm also a CHAP certified consultant. And you're welcome to read my bio if you like. But that pretty much covers it. I will hand it over to Ashley to introduce herself, and then we will dive in on IDG best practices.
Thanks, Daniel. Hi, everybody. Some of you already know me. Some of you don't know anything about me. I specialize in onboarding and training startup hospices on our software, which includes documentation, reports, and dashboards. I am responsible for internal training of my client reps, as well as managing the Hospice Tools Help Center. I curate a lot of external and internal resources in the form of help guides, how-to videos, a very robust FAQ, and we do curate resources from CMS, CHAP, NHPCO, and ACHC. I am also CHAP certified in hospice operations consulting, and I was one of the first attendees for the healthcare leadership certification. And I absolutely love this industry. I'm very passionate about it. For those of you who know me know that. And one of my favorite parts about this job is helping people succeed and contributing and being an advocate for our clients, which enables us to improve our software so that you can spend more time with your patients. So thank you for taking the time to show up today, and we hope that this is going to be very informative for you, and we're hoping to help you in any way that we can.
Okay, perfect. Thank you, Ashley. So starting off, what are our learning objectives here? Obviously, pretty straightforward that we need to understand what the regulations are, what the expectations are of that, and the compliance standards related to IDG. Identifying the common compliance gaps, and going into best practices for how to plan and how to conduct your IDG meeting, planning your IDG meeting, and documenting it to ensure compliance, as well as some tools and features that can help you with that, and strategies for how to move forward after this webinar. So talking about IDG and why it matters. IDG is more than just a good idea. It's really the whole foundation of hospice is based on the idea that you're individualizing for the patient and that you've got a team, right? It's not home health. It's not curative care. We've got a team. You can't even deliver free hospice care, pre-certified hospice care, without having a team in place. So IDG is really where all that comes together, creating an individualized plan of care for each patient, updating that plan of care, and making sure that it's transparent across the team in order to create a coordinated plan of care that's functional and useful and keeps you in compliance. And by the team, we're talking about the required team members, obviously, your registered nurse, your social worker, your chaplain, your physician, but there's also volunteer coordinators, bereavement coordinators, and other teammates who it may be appropriate for them to participate in either the planning or IDG itself. So it's really important that we get IDG right because that is the foundation of hospice. So when we look at the regulatory compliance and CHAP standards, what we have are that IDG must meet no less than once every 15 days. You've got to include those required disciplines at minimum that we just mentioned, the nurse, the social worker, chaplain, and physician, and that per the regulation, you have to demonstrate the active coordinated input from the team. So this information has to be transparent across the team and that it updates, that we take this information and update the plan of care appropriately. And the CHAP focus areas as it relates to IDG is in order to stay in compliance, we're going to focus on timely completion of documentation, the evidence of care coordination, that we've updated our goals appropriately, and that everyone has participated and signed the documentation. So we're talking about here making sure the documents leading up to IDG, things like visit notes, care plan updates, that the team is working together, that everybody's on the same page, and that this information actually is personalized to each patient and appropriate goals, and that everyone's participating. And again, that goes back to the idea that the coordinated plan of care is taking place. IDG is where we're coordinating that care. So it's important that we make sure everybody is working together in a holistic fashion for these patients. And when we're talking about the common compliance deficiencies, we've got things like missing or late documentation, signatures, plan of care is not being updated, patient conditions not being reviewed properly and updated properly, and information being siloed between teams. And the way we really want to approach this are a few tools you could use to help cut down on these very common compliance deficiencies. You've got scheduling software in your EMR, or even if it's not in your EMR on paper, but schedule this stuff out, right? Use your scheduling tools to schedule IDG meetings, to schedule your IDG prep for review so everyone knows when things are happening. Create deadlines in your scheduling software for updates before you're getting to IDG. Use things like unfinished document reports or other visibility tools within your EMR to see what is outstanding. If you're missing signatures, if there's documents that haven't been completed, those are things you can review to see if you have the document at all, or if you have it and you're pending information, a signature, which is should be a simple thing to get, but often falls through the cracks. So you want to have tools that are going to give you visibility on that. Frequencies is another key part you're going to have to check in order to make sure that you're not missing any documentation, because a visit is met when the documentation is complete. So that documentation, the information goes into IDG, but it also really ensures compliance in your previous plan of care, that frequencies are met and that you're having accurate discussions going forward about frequency, as well as something as simple as an IDG tracking report, making sure that no one's missed IDG, that you're seeing each patient at least once every 15 days, that you're reviewing that coordinated plan of care through an IDG update. You're also going to want to look at things like your care plan updates to make sure that those have been done at least once every 15 days, that those have been updated so that the goals are updated appropriately for each patient. So you should have some sort of visibility in a care plan report, giving you the updates and the active symptoms. And importantly, the visibility. So we need to make sure that this information isn't siloed by different clinicians and different clinical teams. So the different team members need to be able to review this information, whether it's in the chart or having the ability to run certain reports so that they can see this information as well, in order that they can update and move forward appropriately, and that everyone is working together. And how do we do that? So it's really about before IDG meeting, that we want to set things up with IDG using a checklist, if you will. We're all very big fans of checklists. I think checklists are amazing. I know Chap's spoken many times about checklists as a recommendation, and IDG is no different. You should have a checklist, and using that checklist is going to help guide you as part of your pre-IDG setup as a normal process that you should be going through every 2 weeks and throughout that 2-week period. So again, what do we want to confirm? We want to confirm that all the documents are in there. We want to confirm that the frequencies are accurate. Those two are tied together. If frequencies are inaccurate, it means your documents are inaccurate. So those have to line up. That we've got a specific deadline that's being met for any outstanding documentation be completed, and that the narratives are drafted and being pulled into IDG, unless you're using a scribe to do it in real time. But if you're not, you should have each team member creating a narrative draft for at least the standard elements of what's been happening with that patient, and being able to update it before or during the meeting for any real-time recent changes and changes of status, goals, and interventions, etc. And we want to identify any outstanding assessments or interventions, right? So if there are any problems that are being tracked by the clinical team, these care plans, these problems should have care plans, and those care plans need to be updated to the most recent information with the interventions by the care team tracked with the outcomes, and all of that should be updated in the care plans. And importantly, you want to review the medications, treatment orders, DME, for specific updates. So you want to get that done before IDG, doing medication reconciliation, things like that, orders. You don't want to get to IDG and then start placing orders for things that should have been done in the days leading up to IDG. Otherwise, that information isn't going to be accurate at IDG. And by doing all this beforehand, you're really going to have a smoother IDG process where we can focus on the narrative, the changes, the updates to the goals and interventions, frequencies going forward for the next 2-week period, by reviewing these pieces of information beforehand and making sure that you have an accurate picture that's across the team. And a great way to do that is to use an IDG agenda sheet. So that'll be a checklist, if you will, that your EMR should create for you leading up to IDG, allowing you to capture these compliance issues such as care plans and the frequencies and these other issues that we're discussing, that they're lined up, grouped by different patient types, whether it's admissions, deaths, discharges, ongoing, who's in their research window. And if you have something like an IDG agenda sheet or IDG checklist, you're able to sort those out in a way that makes sense to how you want to run IDG, starting by groups, and review all that information in the days leading up to IDG. And that's really where we're starting from, is that in order to have a successful IDG meeting and address these common compliance gaps, it has to take place well before IDG, that these are pieces of information that you should be looking at regularly, and then a last look, if you will, through the consolidated IDG checklist or IDG agenda sheet to review these key pieces of data. So that's really where we are in terms of setting up IDG and reviewing it leading forward. And I'm going to let Ashley take it from here in terms of moving forward with IDG.
Thanks, Daniel. All right, let me take control
My pleasure,
here.
Ashley.
All right. So kind of transitioning over from the pre-checklist to more of the QAPI reports and dashboards. So again, very generalized. Your EMR should have these reports and dashboards allowing you to prepare in advance, right? And I believe in proactive versus reactive. A lot of your team members should be cross-trained, in fact, to be able to run these reports in the event someone else is out, or just being able to run them if necessary in order to help everyone out. So starting with a report we like to call the unfinished forms report. So this is intended for you to be able to identify any incomplete clinical documentation. That includes IDG updates, incomplete nurse visit notes, anything awaiting the signature from the medical director, and any associated IDG members, or some of you refer to IDT, same thing. The other element of that report is if any of your team members are currently working on any documentation, it allows you to pinpoint the things that are still unfinished and outstanding that you may want to send a reminder out to complete. A lot of unfinished documentation in general doesn't just affect IDG, but it could affect your billing and claims as well. Next report is the admission audit. So start of care is just as important as ongoing. I highlighted this one specifically because it is a top 10 deficiency as it pertains to SOC, or start of care documentation, which should include your nurse's comprehensive assessment, any other applicable assessments from other IDT members, such as the social worker, chaplain, bereavement. This is intended to identify that everything is completed within the applicable 5-day window. Assignment forms report, another top 10 deficiency. This shows the presence of a hospice aid care plan. So if your patient does have a hospice aid assigned, you as the RN coordinator, being the point of care in collaboration with your other IDT members, should establish the hospice aid care plan prior to the hospice aid conducting the first visit, so they know full well what they're expected to do as far as tasks, frequency, any special instructions, things that they should be aware of, or things that they should avoid. The supervisory visit report. So in connection to you having a hospice aid assigned to a patient, this is a standard or regulatory compliance factor. An RN is to conduct a supervisory visit every 14 days to ensure that the hospice aid is following the plan of care outlined for the patient. The supervisory visit report should identify the name of the RN, the hospice aid that's assigned to the patient, the applicable date in which the supervisory visit took place. The care plan report. So Daniel touched on this in the previous slide. Your symptom-based care plans are just as important. In fact, they're part of the patient's overall plan of care. It's establishing the goal from the start, the interventions that you intend to take. And if those things are periodically changing or they're no longer relevant, it's important that at least at every visit that you are updating them as needed, in case there needs to be any adjustments or perhaps discontinuing the care plan if it's no longer necessary. Also recommended to follow your SMART, which is specific, measurable, achievable, realistic, and timely. Medications. CHAP actually did a fabulous CHAPcast on building a culture of ongoing medication reconciliation, specifically on to October 28th. The reason I'm emphasizing that is just because medication reconciliation, just like care plans, as a nurse, you should be reconciling medications at every single visit. It's to ensure that your patient is still taking the medications necessary. If there's any discrepancies between medications versus, so what has the tendency to happen is what's on paper doesn't match what's in the home, or what's in the home doesn't match what's on paper. This also includes medications that the hospice isn't paying for, so they should be profiled no matter what, which provides a full scope of all the medications that they're currently taking. In addition to one actual very important point, this is a huge survey deficiency. CHAP, CMS, so not just state, but federal level. So if there is any, basically any form of discrepancy that may lead to any patient safety, that could lead to immediate jeopardy. So you really want to take a close look at that. IDG tracker, this is another really wonderful report. It allows you to see when the first and last IDG update occurred for every patient. So if there was a gap or for some reason someone was overlooked, it should identify how many days in between, or if it exceeded the 15-day recommended interval, it should flag you for that to let you know that it's been more than 2 weeks since the patient had an update. In terms of a visit frequency audit report, so at IDG, you're likely making adjustments to the frequency in which you're visiting with patients. So if there are any updates or changes to those frequencies, part of IDG is outlining or updating, if the nurse is seeing the patient 2 to 3 times a week, if they're staying with that same frequency or updating, that should be documented within the IDG update. And if there is a reason to change the frequency, that should be documented thoroughly to identify what changes were made. Your IDG document doubles as an order. So after the update is made, it does go back to every ID team member to sign off and acknowledge that the frequency and all the applicable information pertaining to their point of view on the patient and what's going on is acknowledged by all of those team members. DNR report. So this is a really good one as well. The agenda, as Daniel pointed out a little bit ago, the agenda does identify if somebody is a full code versus not. And so the report will let you know if whether or not you've obtained an actual DNR document from the patient and whether or not your intake screen reflects the appropriate information. And then lastly, another really important one is the recertification dashboard. So this is a Medicare guideline. So if your recerts and your face-to-face encounters are late, per Medicare guidelines, you are supposed to discharge the patient and continue caring for them until a recert or a face-to-face, if applicable, can be conducted. Recert dashboard should identify who's upcoming for a recertification as well as a face-to-face. And if you have nurse practitioners on staff, you can utilize them to conduct the face-to-face visits if the medical director is not available to do so. Recerts, as a reminder, should be conducted by the medical director. Okay. Transitioning to a little bit more reports and dashboards, but these are specific to recertification. So I did just touch on the recertification dashboard. There is a recertification face-to-face report, and that should provide a clear oversight or comprehensive view of past, present, and upcoming as well. Should reflect the due date, what's been completed, and what is still missing as it pertains to those important certs and face-to-face. The unfinished forms, I touched on that. So some of this might sound a little repetitive, and that's because it is, but you should be doing this at the start and throughout. And the reports are there to identify what you probably need to circle back with 1 or 2 individuals about, just to ensure that you don't have any missing documents or signatures, and everything is reflective of what currently is. Moving on to the next slide, going more so, again, a little bit more of a review of the reports and dashboards. So you just want to make sure that as far as your IDG tracking, everything matches what was discussed with the patient, with the family, the frequencies are in order. If you need to make any changes, that you discuss that openly in the meeting. Everybody is agreeable. Everyone understands as far as if there's any changes or updates necessary. Okay. And now we want to talk about death and discharge. So death, discharge, revocation. So as far as a deficiency, number one, if a patient revokes the election of hospice care or is discharged from a hospice, you want to make sure that you're forwarding the copy of the discharge summary to the attending physician. And of course, that's if they elect one, just so they're in, they know. To avoid the deficiency, again, using your reports, we have a lovely report called a discharge report, and that'll identify when the patient has expired, revoked, discharged. It provides visibility to completed discharge or death summary and or both. If for death, whether the death visit was completed, if discharge document was completed. So you want to make sure your documentation reflects your administrative details. And when I speak about that, I'm talking about the intake screen. So in a lot of EMRs, that basically when you change the status or the dates, things like that, those are all connected to your census, which is also connected to billing. So you want to make sure the levels of care and the dates are all matched up with the documentation. In terms of another deficiency, patient individualized written plan of care. So Daniel did touch on that as well. So at the start of care, it's establishing comprehensively what the goal is for each patient. Everything should be individualized in terms of care plans. You're not going to do the same exact thing for every single patient. So you want to make sure those are measurable. Same with drugs and treatments. Care plan report that ensures that if a care plan is still a problem or being tracked, that you are consistently making updates. I often get asked, do I have to update that symptom-based care plan all the time? It's as often as necessary. So if there is even a fragment or a little bit of a change to something, you should document it. As they say, document or it didn't happen. The comprehensive assessment, that should include the drug profile that contains the patient current prescriptions and over-the-counter medications. We touched on medications a little bit ago as well. I mean, it is a big, big deal. So you want to make sure that your dashboard, your medication, your PBM matches the EMR and vice versa. That includes, again, things that you are not paying for as a hospice. It doesn't matter. You still want a full scope of what they are being given and what's in the home. So documents matches what's in the environment and vice versa. End of life visit count. So this is a big one. This allows you to keep track of the percentage or number of visits completed by the RN social worker during the last 6 days of life. When used prior to IDG, this actually enables you the ability to identify whether the appropriate number of visits were conducted in association to the frequency for the assigned discipline. And this can also be used in conjunction with the visit frequency audit report. All right. My little bubbles there just appeared. All right, and now we transition to the meeting and effective IDG execution. So some examples of that, scribing. Anybody can be taught to run the agenda or how to update. And of course, it still has to be acknowledged by the actual clinical team, so the members of IDG. It's always a good idea to cross-train and make sure that a lot of RNs, I know some clients, they like to rotate an RN every 2 weeks to get comfortable with updating each plan of care. Some clients will mirror the agenda up on a big screen and update each plan of care together. Some people still like to print it out and make the updates after the fact. It has to work well for your facility. That's based on census and the number of employees and how much time you have to. There's different ways of conducting. As we all know, some of you are so large, you have to have people call in. That's perfectly fine, I'm sure. And then sending and sharing information is also very, very important. Let's see. You want to make sure that your IDT members have provided the most up-to-date information about their patients. And as Daniel hinted at the start of this meeting, you want to establish a clear, concise cutoff time, right? The update of the patient should be the last possible interaction that the RN, the social worker, the chaplain had prior to the next update. So you're bringing forward the most current information about the patient. Individual care plan should be updated as often as needed or necessary, and this should occur at every visit along with reconciliation of meds. An example of this, if a medication is no longer needed or it's no longer helping, it should be discontinued prior to the meeting. You might have to discontinue something while you're in the meeting, but the less you have to reconcile at IDG, the quicker and more efficient you can move on to the next review of a patient. If someone needs to follow up on any missing or confusing or conflicting information, this should be clearly outlined in your meeting minutes with actionable follow-up to anything that is not certain or confirmed and properly documented. Right. And this just reiterates what we've already discussed, right? So you're documenting in an IDG meeting, most of the items in an IDG should automatically populate. When we talk about that, that's more so frequencies. So in the software, whatever the last applicable frequencies are should pull forward. And if there's no changes, that makes everything pretty clear and concise there. Or if you need to update the frequencies, you'll do so in the moment. Patient summary and conditions, you want to make sure all of that is up to date. Any changes to DME or interventions, any input from disciplines, updating care plan goals, updating frequencies, changing or confirmation. If you have an active attending physician, you want to make sure that you are interacting and collecting any comments or anything that they have to say about the patient. If they have any input, that should also be documented in the IDG. So they're collaborating with your internal medical director. So if they're not speaking to them directly, if they sent you an email or a text message about something, it's probably, if it's pertinent, you want to make sure you include it in your documentation. And most importantly, every IDG update serves as an order. So once the MD signs off on it, it is an official document along with the other applicable signatures as well. And this also doubles as your new and update frequency order form. All right, e-signatures and attestations. So we just kind of touched on that. So number one, automatics. So as much as possible, but not too automatic, right? We still want to make sure that we're pulling in the correct and most up-to-date information and actually making any manual changes as necessary. Remember, your care plan from the start and throughout till the very end should be individualized, and it should change if necessary. Plan of review, care notes, all the things. They should just be constantly evolving if necessary. Next slide. So post IDG. So we're kind of wrapping up at the end here. So kind of do what you did, redo, and circle back essentially. So number one is scheduling. So ensure your scheduler or the individual responsible for scheduling, because some of our clients have a master scheduler. It is their job to ensure that the schedule reflects the frequencies and the disciplines assigned to the patient. So you want to make sure for scheduling that those updates, those individuals are made aware. If there have been any changes to the patient schedule, this includes the patients and the caregivers as well. So you should have the ability to print a schedule for your patient, for your caregiver, so that they are well aware in advance of when to expect the clinical team members at their home or facility. This should be updated immediately in your EMR's calendar or whatever scheduling tool your facility is using. So everyone is part of the patient's team, essentially the who, the what, the where, and the when. Okay. Frequencies, any changes to frequencies should be properly documented and signed off by all applicable team members. Frequencies go hand in hand with scheduling. So if your calendar is missing the frequencies, it's great to have a schedule, but it's better to have a schedule with an identified team member and the applicable frequency in which they should be scheduled. Knowing how many visits are needed for each discipline in order to create a clean schedule. This is also associated with your visit frequency audit report, which would identify the set number of visits and how many visits were actually completed in the applicable time frame. Communication. This includes the communication that you have with your colleagues, your care team members, the patients, the family, the caregiver is extremely important. Continuous communication is important because it ensures that everyone's on the same page. Nothing gets misunderstood, miscommunicated. Everyone understands if let's say the caregiver is supposed to administer medications. Are they clear about those instructions, how often to administer the medication? If there's any confusion or even maybe a flick of uncertainty, you should identify that early on, get them to acknowledge, get them to sign that they understand everything. And then make sure you have copies of that, or if they ask you for a copy of that, that you're able to provide that. Communication goes hand in hand with coordination. So if the patient resides in a skilled nursing facility, for example, it's important to ensure that the most up-to-date documentation is provided and that those parties confirm their understanding of the current plan of care. You can get them to sign off on and acknowledge that they understand. I'm sure a lot of the systems allow for that. So you could get an e-signature from that applicable facility, from the point of care person there that understands and acknowledges they have reviewed and understand. You can and should encourage signatures of all skilled nursing facilities to acknowledge. And again, you can do that wet signature or electronic. Signatures, not only to observe or serve as the purpose of acknowledging the care team member participation for patients' updated plan of care, but it also holds team members accountable for their role in the patient's care. Signatures confirm the care team member contributed to the patient's plan of care update, but also reflects that they acknowledge what the plan for the patient is going forward, tentatively for the next 2 weeks, unless otherwise necessary to update prior to the next IDG meeting. Most importantly, signatures solidified what was communicated, agreed upon, and what was updated. And it looks like we ended pretty early. So Denise, I don't know if you want to open it up to questions. I saw a hand go up.
Well, actually, there's lots of questions in the Q&A. And so for anyone who has their hand up, just so you know, there's you're muted and the camera's function is turned off for you, but you can absolutely post in the Q&A. So I'll just start with a few of these questions and hopefully we'll, we can make it through a few of them in the next few minutes that we have available. I'm going to just start from the top. So this one is saying that one CHAP surveyor said that we have to do a comprehensive assessment for each patient for IDG. In Hospice Tool, that comprehensive assessment is the same as initial assessment. Do we have to do it? Just narrate it in IDG? Thank you. Does that question make sense?
It does. So in our system, it sounds like a current client. So essentially there's the initial comprehensive assessment, and that's intended for the start of care. It's applicable to HOPE. It has the HOPE fields in it. You use that for a new patient always. Then for the nurses, they have a couple different documents they can use for scheduled visits. So what you're wanting to use, or what you should be using, is the nurse comprehensive visit note. And that's under the nurse tab, and that is a comprehensive visit note. So if you're looking to do that, minimally, we recommend that your RN's using that minimally every 2 weeks, but we have clients that use that for every scheduled field visit.
And just to flesh that out a little bit more, some of this can also be a bit of a language thing, the way you could be in palliative care and hospice is palliative care. So the reg is that obviously you have to comprehensively assess your patient every 2 weeks. That's different than a title of a form called initial comprehensive assessment. So when a patient comes on care, you've got to get your 2-day meeting done, the initial plan of care, you've got 5 days for get the full comprehensive assessment done. And then at least once every 2 weeks, the RN goes out and comprehensively assesses the patient. And that's done through the RN visit note, which also includes the supervisory visit. Some agencies will have their LPN, LVNs also use that document, or they'll often have them do a shorter document, like an abridged visit note, which is tracking less information, and leave the comprehensive visit note to the RN biweekly. And then that information together makes up, if you have two frequencies, a frequency of 2 for the nurse for that time frame, for example. So you might have one abridged note from the LPN/LVN, depending on where you are and what they're called. And your RN will do the nurse visit note, which is which comprehensively assesses the patient, as it's a much larger document, far more metrics, as well as including the supervisory visit. They should also care plans are attached there, so that's a great opportunity for them to update their care plans with anything that's come up during that visit, and then use that information, what they've tracked in that where they've comprehensively assessed the patient in their RN visit note, plus any care plan updates they've done. That information is really the springboard for their narrative for IDG. So hopefully that clears up the process of differences between comprehensively assessing and a comprehensive assessment.
Thanks, Daniel. And I am going to actually try to sort of sift through a few of these questions for things that are a little bit more generic to any system use, because I do want to encourage folks who are using the Hospice Tools software to reach out to their representative, whether that's Ashley or Daniel or someone else at Hospice Tools, to ask some of those really specific system questions, because that's obviously going to be different depending on what folks, if folks are using a different EMR. So there are a few questions that are a little bit more general. And I'm going to just start with this one. Is volunteer coordinator required to attend/sign for IDG meetings or IDT meetings?
Generically speaking, if there is a volunteer assigned at the start of care, then yes, the volunteer coordinator should be included in the initial plan of care, so they're aware that a volunteer has been requested. Throughout care, it's always a good idea to include them as well. Obviously that could change, right? I know a lot of hospices on here know that at the beginning of care, they may not be interested in a volunteer, but then they might change their mind. So that in turn, that is a good reason to start including them in the updates.
So, and just to add on, and technically, they are not part of the core service that is required by the regulation. That's the RN, social worker, chaplain, and physician. But it is absolutely a best practice, and especially when they're involved with the patient, if they haven't been refused. But even if they have been, they could simply put in as a narrative, if you want to include it, that they're working on it, we'll follow up, whatever it might be. So it's certainly a best practice because, again, IDG is all about coordination across the team, not just the minimum required clinicians to participate and sign.
That was a great answer to that, because there's also another question about what disciplines are required to attend the team meeting. So I think maybe just elaborate a tiny bit more,
Sure.
if you would.
Right. Again, you've got the RN, the social worker, the chaplain, and the physician. Those are the disciplines that are absolutely required, and you can't get around those. And then everyone else is a best practice to include.
Okay, thank you. Now, this one is about the timing on signatures. So it's asking, how soon can you sign the notes, the IDG notes, and is it best practice to sign the day of?
So whoever in our system, so I don't know how it works in others, but in our system, whoever gets the designation of updating the actual plan of care, once that person hits the button, the sign and submit button, we have what's called personnel selectors at the bottom, which are the core. I like to call them the core 4 people, but they select whoever is applicable or whoever is assigned to the patient. And once that button is selected, then the actual IDG, the full updated IDG document, filters to that discipline's dashboard under a task box. And then it brings it forward so that applicable person can just immediately sign off on it after they've reviewed it. So it takes literally a couple seconds, as long as that person has actually, the other person that updated the care plan actually hit sign and submit. If it's left unfinished, it doesn't filter to those applicable team members in the system.
Okay.
Yeah,
Thank
and
you.
just add a little bit more because signatures are really important. And it seems like in a lot of systems, or you might even be on paper, it can be difficult to get them all and get them all timely. So yes, getting it done within 24 hours, I would think of it as same day charting, right? You should really get your documents done same day, unless there's a good reason not to. It's the real world, right? Hospice doesn't go by a textbook. So you're certainly going to have times, maybe you've got an involved attending and you need to go get a wet signature, or you need to send something off to them by fax or DocuSign, whatnot, to get it. But at least your core, those 4 required ones, and they just participated in IDG. This is their responsibility, and IDG is not complete until at least those 4 signatures are on there. And certainly you need the doctors right away, because your IDG is your frequency order going forward. So without that doctor signature, you don't have a compliant order for your plan going forward. So those 4 you should really get the same day. And everyone else, if it takes another 24, 48 hours, isn't as big of a deal.
Okay, thank you. This one's with regards to medication. So I'm just going to read the question as it's written, see if we can kind of decipher through it. It says, does each medication need its own individual care plan, or can you care plan the type of drug or symptom being addressed, and the specific drug would be an intervention?
So I'll take that then. Some of this is system specific, because different systems do it differently.
Okay.
You know, if you're got a system where your care plans are based on meds or based on problems or ICD codes, I mean, that's an approach, but that's somewhat, you know, in hospice, it's all about symptom management. The point of doing a care plan based on a symptom is you've gone out to see the patient, you've got pain, for example, you've got a cough, whatever. And what are your goals, your measurable goals to deal with that problem, that you want to achieve for that problem? And then you're going to create interventions related to that symptom. And that would include pain, you know, the different meds and other interventions you and the team and others are going to work on in order to achieve those goals for whatever problem the patient has. So that's our approach, regardless of our system. From a hospice perspective, everything's about symptom management. So starting from this patient has an ICD code and is taking these meds, and what are we going to do for that problem? You know, a patient has liver cancer. Okay, it doesn't really matter per se, because you're not treating the liver cancer. You're not trying to cure the liver cancer. What we want to focus on are what are the symptoms that this patient is having because of it. So any activities, any actions, any interventions, any meds, anything else you're doing should be slotted in based on what the symptom is, not based on what the disease or the med is, in our opinion. There's some gray area there, so but that's where I'm coming from on it.
Okay, thank you. Just one thing again, Sherry, I see a hand up, and the microphone and camera abilities are turned off for the webinar. So if you can post a question in the Q&A, I will try to get it posted for you. This is actually related to medication, so just kind of staying on that same topic. There's a question with regards to having a hospice pharmacist working on the medication reconciliation for this person's hospice. How can that be documented in the IDG? And this is specific to your system, but I feel like just in general, that's a good question.
We have a couple plans actually that do that, and you would create a profile for them in the software to provide them access, and then we could construct a document for them to make that connection between your IDG update. So if you want them to be able to contribute or to, make notations that they were responsible for that, there's always a way to do that, and there's more than one way to do that. Daniel, I don't know if you want to expand on that.
Sure, absolutely. So, and not just in our system, in every IDG, there's, free text areas. So whether they're contributing directly or you treat it similar to comments from an attending where you've gotten information and you're entering it into your IDG document on their behalf, they may not want to document line, but, patient by patient on a separate progress note for each patient or be a user in your EMR per se. They could easily send over a spreadsheet and you copy and paste the relevant comments in. So there are lots of ways from a functional perspective in any system to make that work. I would say that the more information you can have on meds to make your narrative more accurate and make your care plans more accurate and make your goals and interventions going forward more accurate, and that's reflected in a coordinated plan of care, because that's, again, really what IDG is, where you're creating your coordinated plan of care. It's transparent across the team so that everyone knows what to do going forward. What happened the last 2 weeks? What should we be doing for the next 2 weeks? And meds are such a tough area of hospice. I think everyone in hospice knows this, how difficult that can be, and lots of ways to manage that. So my take on it is anything you could do to get the more accuracy and more information there as it relates to meds is certainly going to help you stay more compliant on something that often comes up in survey.
Thank you. I like this question. Do you feel like including HOPE data, certain aspects of the HOPE assessment in IDG would be beneficial for audits?
Ashley, I'm going to let you take that one.
Oh, HOPE. I think we should do a HOPE webinar next. So if you think about it, I say yes, but information changes often, right? So what you're assessing from, I say the first 30, right? Because you do the comp assessment, then you have HUV1 day 6 through 15 and 2, 16 through 30, and then SFEs if applicable. So you got a lot going on there in between. So the whole point of the IDG narrative, right before the meeting, what's the most current up-to-date information? What is going on with that patient? And it may or may not be the same as it was the first week to the week 4. So what CMS is asking you for is that first set of data from the get-go. And obviously you're keeping track and updating and documenting after all of those applicable timelines have been met. So I suppose if you wanted to do that, we could try to figure out how to do that. But we found that the best way to do that is always just submit the most up-to-date update or information, because it does always change, right? And it can change.
Yeah, and I think the most applicable place for that, really, if you want to pull HOPE metrics, would only be for new admissions, and you've done HOPE, and that is the most relevant data, and now you're getting to their first IDG. Because really, after that timeline, it becomes about your regular visits and care plans that and orders, obviously, med orders, treatment orders, DME orders, that as part of ongoing care. And they should be reviewing for those for that first IDG for people who have been admitted since your previous IDG. That nurse, as they're drafting their narrative, should absolutely review their comprehensive assessment, which is what HOPE information pulls from. So whether it had HOPE in it or not, that comprehensive assessment is a key document to review when creating the narrative for your new admissions first IDG.
Thank you. Okay. I'm gonna do two more questions. So my first of the last two is, are you expected, this is a good one for folks who have patients that are in facilities. Are you expected to fax or provide IDG updates to the plan of care to the facilities after every IDG?
Yes, absolutely. That's your coordinated plan of care. And it's certainly something that you're going to want to have in your hospice binder at a facility. And it's best if you even have a signature on it, though that's not required. That's just a nice best practice that they've acknowledged that they've received it. You have a copy of it for your records, that you've sent it over, because often that binder goes missing when their surveyors show up. So that's good for your own agency to have. But yeah, that's your coordinated plan of care document. And you're already in contact with them. You have people going to that facility, fax it, send it by DocuSign. But I would highly recommend that that be included in the documentation sent to a facility.
Great, thank you. And again, I'm gonna try not to focus. There are some questions still in the Q&A that are really specific to Hospice Tools, and I'll do my best to download these questions and provide them to Ashley and Daniel so that they can potentially address them with the individuals posing them.
We'll definitely get back to anyone who has Hospice Tools questions, but we really want to keep this, informational for everybody.
Yes, yeah, absolutely.
Yeah,
So
because
this
it's
last
key for
one,
hospice. Yeah, go
I
ahead, please.
appreciate this question because I'm expecting that there are others who have this problem. And it's with regards to an MD that only wants to focus on patient declines during IDG just to justify keeping them on hospice, rather than discussing the plans of care, et cetera. How do we get a physician to change their focus? Any thoughts or tips on that?
How do we get a physician to change their focus from who's in decline and to deal with what, your ongoing and admissions?
Well,
And
rather than just focusing on the decline for the rationale of continuing to keep a patient on service, how do we get the physician, the physicians to change their focus to what the holistic needs of the patient are versus just to the decline?
right, understood. Some of this comes down to, are you buying into the hospice philosophy? And to me, this sounds like a physician who might need a meeting, a webinar, a consultation, a discussion. I can't really think of, there are things you could do in the meeting, keeping declines towards the end and making sure they meet with the nurse for the research after IDG, so they can't just do the IDG, the research at the beginning and then, call it and leave and call in and put everyone on mute or something. So there are logistical things you can do in terms of how you set up IDG and when you do things in order to get that physician more involved. But this really is a philosophy that it's not just about getting more days on care and recertifying folks. And you have to buy into and have the passion for hospice. And I think, as everyone here knows, if you're in hospice, if you're not passionate about it, you don't last very long. So I'd say this is a physician that maybe needs to really buy into what hospice is more than just, can I get more days on care? And that's not really a tips or tricks issue. That's something that comes with some education and working with those patients more than just signing off on some documents. Maybe have them go see some patients as a training
I would
session.
agree. That sounds like box checking, and I didn't speak about it, but Medicare is taking a closer look at your documentation. It's not just titles and labels and do you have it in your chart? They're looking at the substance. So I could go on all day about that. We don't teach that obviously in training. It's about the software, but there's a lot of articles out there right now circulating because people's claims are being rejected because the physician's documentation doesn't match with the nurses and etc. So it can't be subjective, but they are looking at that a lot more closely.
Thank you, Ashley. Yeah, I
Mhm.
totally agree. And I think it's a great question, but it also might just be, is that the right fit for the organization? Do they have the same values? Are they mission driven? Right? Are they really bought in to the hospice philosophy in general? So, but thank you for the question. It's a really good question. So that is all the time we have for today. I just want to reiterate that a recording, you will get an automated email that the recording is available to you. That is not spam. That is a real email with a link to the recorded session. If any of your colleagues were unable to attend and they registered, they will get that link as well. I really appreciate your engagement and your questions and for showing up today for this great conversation. Want to thank Ashley and Daniel for taking the time to put all this together for us. I will do my best to get those Q&As downloaded and over to Ashley and Daniel so that they can reach out to any of their customers with specific answers to those questions.
For sure. And happy to answer questions from others as well. Don't have to be a
Yeah, of
client to
course.
get
Of
help.
course.
So any questions you want to send. And again, I'll just reiterate what Denise said. Thank you, everybody. Great questions, fantastic questions from the few we were able to get. Appreciate everyone showing up and sitting through us talking. And I appreciate everybody and keep on doing the great work you're doing in hospice.
Absolutely. Have a great rest of your week, everyone.
Thank you.
Thank you.
Bye all.
Bye.